Pediatric BE. Some indications for pediatric BE: potentially severe constipation, Hirschsprungs, intussusception, trauma or sexual abuse, abdominal pain, rectal bleeding, IBS, weight loss, pre-op surgery, post-colostomy. Types of contrast you might see, potentially the BE using thin barium, water-soluble enema. The older kids are usually the ICView 300. NICU babies, we're going to use the VisiPig. Remember, VisiPig has the least potential for reaction. And then the air-only enema would be if the child has intussusception. So some BE preps for kids, these are determined by the ordering doctor. We don't determine these. So these are just some examples, right? So kids 0 to 2, no solid foods on the day of. Remember, little kids, they have really fast working systems, right? So they eat all the time. So depending on the time of their exam, they're just not going to eat anything. 3 to 5 years, they have a prep potentially before. 6 to 13, right? There's going to be definitely more involved. If they have Hirschsprungs, acute abdomen conditions, and active IBS, they're not going to use any prep. So that'll be determined by the doctor. Some room prep setup, really similar to that of adult radiologists or adult BEs as well. I always ask the rad, what contrast do you want to use? The radiologists most likely have looked up the patient history, why they're coming in, indications, what's going on. Am I using barium? Am I using water soluble? What type of water soluble? Something like that. I always pull out enema tip options, especially with kids working in the PD fluoro. I don't know if they are going to be the size of me as an adult. Pediatric tips for the smaller babies, blue and green. I like to have options. I like to have everything out in my room I could possibly need, right? Sheet, mat, sheet, lots of chucks, especially the babies. They do not hold anything in, all right? So once your linen is wet, it shows up as creases in the image. So I put a bunch of chucks down just in case. Tape. Depending on your radiologist, they like certain types of tape. Dr. Polanski, he loves that silk tape. O'Connor likes the big, thick tape. Or he does the adult enema tip. You'll start to notice their preferences. Some sort of lubricant. Some prefer gel, and some think the gel makes everything too slippery, so they'll just dip it in a little bit of water. If you have, depending on the tip you use, you may need a connector. So the blue, the smaller, we call it that Christmas tree. It's that long triangle connector. You might need to use that. Extension tubing connected to a contrast bottle. If you're just using ICView contrast for a small child, you don't need to put it in one of those big plastic BE bags. You can just connect the tubing right to the bottle and hang it on that IV pole. Extra blue clamps, and I always ask my rad if they want a scout before I start, because if you forget to ask, then you're not able to do it. And some of them are particular about it. So, would you like a scout? Yes or no? If no, you just call them when you're ready. In our clinical site, the radiologists tip the pediatric patients. Technologists do not. Wherever you work, they may have a different protocol, so make sure and check on that. Communication. Speak both to the parent and the child. All right. Simple terms to explain the enema exam to the child. Get on their level. Don't be afraid to kind of get down on a knee, speak to them eye to eye instead of towering over them. Try to set up as much as possible prior to bringing the child in. Have everything out that you could possibly need, because if they start kind of throwing a fit, you're not going to have a chance to go run to the stock room and find things. So always do that. I always tell them I have a treasure box at the end. We have a red treasure box with toys in it that they can pick something out. Bribery goes a long way with kids, okay? Just an example here. So this child, if you can see this rounded area here, most likely rounded area of stool. There's stool within here. This sort of fuzzy appearance here is usually stool in the bowel. This is us putting contrast in, starting in a lateral position. You can see this is so big right here. Okay, this is a big expanded area. We turn the child supine, continuing to flow with contrast, finding any dilated loops. Just more pictures. This is obviously an example of those fluoro pictures, right? On fluoro, the contrast is going to show up black. Our x-ray overheads are going to show up white, okay? Possible overheads at the end of a Pedi BE. So you might do a scout prior to. Potentially you could do a supine KUB immediately post, and sometimes we do try to get a post-evac. If it's a little baby, we ask the parents to kind of wait around and see if they go in their diaper, and then we'll do a KUB at the end. But I would say overheads for Pedi BE is rare. Hirschsprung's disease. So it's a condition, it affects the large intestine, and it causes problems for patients with passing stool. It's usually present at birth, or congenital, okay? Result of missing nerve cells in the muscle of the baby's colon. And a newborn usually can't have a bowel movement in the days after birth, so that's usually their alert right there. So it's uncommon for it to be diagnosed as an adult. Intussusception is when the segment of intestine telescopes inside of another, causing an intestinal obstruction or blockage. So it can occur anywhere in the GI tract, but it's usually at the junction of the small and large intestines. All right, and there are some visual signs, but the male to female ratio is 3:2. It's most common in 5 months to 3 years. It's accounts for 25% of the abdominal emergency in children up to age 5, and 75% of cases they have no clear disease or trigger cause. They don't know why it happens, and it's usually a sudden onset for the kids. They get this abdominal pain, they start crying, finally they get to the doctor's office, the doctor kind of suspects that this might be going on, they hit the emergency room. Usually it's an ultrasound first, then us, and then we have to kind of get that taken care of. So it can be termed a couple different ways. So it has this maybe coiled spring appearance, or this target with a meniscus sign appearance. Okay, so the target sign would be here, all right, and meniscus, or like a semicircle, okay, a crescent maybe, all right. So the target sign is a soft tissue mass here. It's usually seen in the right upper quadrant, and then the meniscus sign is a crescent of gas within the lumen. Crescent sign here. Here you go, is a crescent moon picture similar to that. Ultrasound sign. So the sign on ultrasound is sometimes called a donut sign. Kind of looks like a donut here, all right, because it's telescoped into itself. So instead of a contrast enema, we use a kit and do an air enema. So your rad might ask you for the intussusception kit. We have this black little tackle box at our site too. With this equipment here, there's specific tubing that's used for this kit, along with this locking system. You're going to have some tips out, have Chuck's lube, a DVD, right, because we do a video of all Pedi fluoro cases. Benefits of an air enema: it's minimally invasive, minimal radiation, they don't take a lot of images. We use a DVD. You can try and avoid surgery. So what they'll do is they'll pump that enema, that air into the colon and try and open up that obstruction. And 7 out of 10 children are successful. We can attempt up to 3 times to reduce it before they go to surgery. There are risks. There's possible perforation. You are pumping air into someone's colon. If it's not watched carefully, they can perforate the bowel. If they perforate the bowel, bacteria can be introduced and cause an infection. There is a recurrence with 2 to 3 days for 1 in 5 children. So that's why they keep them for observation afterwards to see if it's going to come back. If we can't reduce it, they have to go to surgery and reduce it themselves in surgery. So air enema, as you can see, the air is coming through here, up and over, but it's stopping here. So there's clearly the obstruction right here. They got to drop it down and keep dropping it down. Once it comes all the way across and they see it pass into the small intestine, then they know they've come all the way through. So air is stopping here. You can see this rounded portion here, kind of this mass. It goes up and over, pushes it all the way down, all the way through, and kicks into the small intestine, so they know that they've gotten through. I would say an overhead we don't do most often, but you could be asked for a KUB and potentially a left lateral decubitus looking for perforation, right? Left lateral tube, we're going to see that free air, that pneumoperitoneum. We want to look kind of on the right side, right? Because air rises, and I want to put the right side up with the liver and not the left with the stomach. You may, another one we might do is an enema through colostomy. So it could be adult or pediatric, all right? You're going to use a water-soluble contrast. You're going to ask your radiologist if they want a hand inject or they want contrast in the BE bag, and you're going to use gravity. An adult Foley catheter with a balloon. You're going to use, instead of the BE enema tip, you're going to use a syringe to fill the balloon that's attached to the adult Foley. Lubricant, towels. Patient will remove their colostomy bag, and radiologist will place the catheter. It could be pediatric, look at that little PD bag, or adult. They have different types of bags as well. Okay. The colostomy is an opening in the abdominal wall that's made during surgery. So as you can see here, they had to remove part of this intestine and place a bag here. The end of the colon is brought through this opening to form a stoma. When you look at the stoma, you're actually looking at the lining, the mucosa of the intestine. It looks like the inside lining of your cheek, almost. It'll look pink to red. And then, so they do not have use of their rectum during this time that they have a bag. So everything is emptied into the bag. Sometimes we'll do an enema through this ostomy. They remove the bag and the tip goes right through there, and contrast is run through to check everything, and then they can be reattached. And that is the end of that.